Essa é a reunião clínica da disciplina Nefrologia, da Hospital do Rim, da Fundação Oswaldo Ramos. Hoje nós temos o prazer de contar com o Thomas Pham. Ele é do grupo de acadêmico da Universidade de Stanford. Ele é diretor do Programa de Transplante com Doador Vivo nessa universidade e também diretor do Programa de Transplante Pediátrico nessa universidade. Ele é graduado, ele fez um treinamento assim, que somando tudo dá muito mais do que ele parece de idade. Ele tem 9 anos de treinamento para começar a fazer um programa de transplante, para ser contratado por uma universidade. Ele tem mestrado, doutorado e residência em cirurgia na Universidade, Ohio State University. It's a pleasure to have you here. Again, thank you for coming. And also, we are together to develop the transplant program in some African countries. And today we have here also Professor Emmanuel and Victor, that they are coming from Zambia to stay in our institution for 2 weeks. And Tom will be here for 1 week. He has this speak today. And also he's already invited to come to Thursday at 7 a.m. to speak especially with the surgeons. So thank you for coming, and it is a pleasure to have you here.
Bom dia.
Bom dia.
That is all the Portuguese I know. But I want to thank you, Dr. Medina, for inviting me here to Hospital de Rim to talk and to meet with the wonderful team that you have here. Surgeons, nephrologists, clinical research students, all your trainees. And I want to repeat what I had said earlier in that I came here because of the reputation that Hospital de Rim has in the world as being the leading kidney transplant center in the world. It is very impressive what you have done here, and your reputation goes beyond Brazil and all throughout the transplant society. And my interest in coming here is I am an educator. I train surgeons in the United States, and I am in charge of our own fellowship. I am very interested in developing education, not just in the US, but outside the US, and helping train surgeons, such as Dr. Mapalonga and Dr. Liche in Lusaka, Zambia. And coming here, I hope to learn more about how you train and how you teach and how you can develop a kidney transplant program, okay? And so thank you very much for having me here. It is an honor. And so the talk I'm going to talk today is about the future of transplant surgery training. All right. So I'm going to talk today about the history of kidney transplant, the kidney and liver transplantation today in the US, in Brazil, and worldwide, and US training guidelines for transplant surgery training. And also talk about the potential for transplant training here at Hospital de Rim and also Sao Paulo. So as we know, the first successful kidney transplant was done nearly 100 years ago in 1954. Much research was done to look at the immunology behind transplant. And so the first successful transplant was done between 2 identical twins. No immunosuppression was used. The recipient lived for an additional 8 years afterwards. And the surgeon and the team here is Dr. Joseph Murray, Hewlett Heckert. It was the surgeon who did the nephrectomy. This really sparked the beginning of solid organ transplantation across the world. And so after 1954, we started doing kidney transplants in people that were not identical, right? And this was really done between 1960 and 1980. Immunosuppression at that time was very basic and included steroids and azathioprine. Although we achieved success in kidney transplantation, there's very poor long-term graft survival and long-term patient survival. And looking at the history of Brazil, the first kidney transplant was done less than 10 years after the first kidney transplant in the US in 1964. And because of the lack of good immunosuppression, you had similar outcomes, such as the rest of the world. In the 1980s, kidney transplant really began to develop. And that's because of the drug cyclosporin was introduced, which allowed us to use less steroids and allowed us to achieve long-term graft function and survival. Several years after that, later in the 1980s, tacrolimus was introduced. And that's the drug that we use today, as you know. And so the number of organ transplants performed increased exponentially worldwide. This gave way to heart transplantation, lung transplantation, liver transplantation, which had very bad results in the 1960s and 70s. But with cyclosporin, was able to achieve success, especially in the early 80s. And this happened all across the world. And this is taken from one of your papers and looking at the evolution of kidney transplant in Brazil from 1978 to 2018. Much like the world, in 1980s, we performed more kidney transplants, and especially in Brazil, Brazil soon became one of the world leaders in organ transplantation. And this is only up to 2018. And as you can see here, really deceased donation really evolved in the year 2000 and increased quite a bit. Moving beyond 2018, this is looking at the registry, the GODT with the Global Observatory on Donation and Transplantation. Again, looking at the absolute number of kidney transplants done in Brazil from 2004 to 2024, you could see Brazil now does on average about 6,000 transplants, if not more, per year. And that dip there is what we saw in the world with COVID in 2020. Right? And so when you compare this to the rest of the world, you can see Brazil is right here, top 4 in the country, in the world, as far as absolute number of kidney transplants, only behind USA, China, India. Right? But when we look at per million population, how many transplants you do for your population, one thing I learned about Brazil is that Brazil is the 7th largest country as far as population in the world. And so by the number of transplants that you do, you rank about 30th in transplants per million population. But before I move on, I just want to mention when it comes to liver transplantation, that Brazil again ranks number 4 in the country, in the world, as far as number of absolute number of liver transplants performed. And so what I take away from this is that Brazil is a global leader in organ transplantation. When it comes to abdominal transplantation, which is mostly kidney and liver transplantation, Brazil ranks number 4 in the world for absolute volume of abdominal transplantation. As you all know, and the reason I came here is Hospital RIM has a reputation for being an excellent transplant center and has performed the most single-center kidney transplants in the world. And your reputation goes beyond that you're a global leader in transplant and health equity with the largest public health system in the world. All right, so many countries have public health systems, but Brazil has the one that serves the most people. All right, and so it is by far the world's largest public health system. And through that, you're able to perform organ transplants for the majority of the population. And so what about training? Brazil, as you all know, and what I have learned, is a leader in organ transplantation. And so going back in time to talk about the training of transplant surgeons in the US, we created the American Society of Transplant Surgeons. And this society was actually created in 1974, really before liver transplant was very successful, as that liver transplant was the first liver transplant was done in 1963 by Thomas Starzl here in Denver, Colorado. He then moved to Pittsburgh, Pennsylvania, and then continued to refine his technique and then perform the successful and long-term liver transplants. And during that time, he had many surgeons with him, some from the US, many from outside the US. And when you look at the surgeons that learned how to do liver transplant with Thomas Starzl back in the 70s and 80s, they really came from 3 main areas. They came from Brazil, and they represented all of South America. They came from Japan, and they also came from Europe. And so he had groups of surgeons, many non-US surgeons, involved from the very beginning to help him refine this technique and develop this. And because of this training, they developed the American Society of Transplant Surgeons. And our first president was Dr. Starzl. And he created this society to make sure that surgeons are trained properly in transplant surgery. And what the training in the US has evolved into is that we have what we call our Transplant Accreditation Council. And this is the council that oversees all of the training programs for transplant surgery in the United States. We have approximately 66 transplant fellowships in the US. These fellowships can range from a kidney transplant only, kidney pancreas, kidney liver, including intestine. And so it ranges from what organs they train you in. But most centers offer kidney and liver transplant training. These centers graduate approximately 40 to 50 fellows per year. All right. In 2018, like I mentioned before, when we looked at this paper here that looked at applicants between 2006 and 2018, less than 30% of the applicants were from the US, which is also good too, because that means 70% of our applicants were from outside the US, interested in learning and to train about transplant surgery. We did do changes to make transplant surgery more appealing to US grads, in that we changed training to accommodate lifestyle so that bigger teams were formed so that we could perform transplants during what we call business hours instead of working all night. And we also combined training to involve hepatobiliary surgery. And so now in the US, many centers offer transplant training and hepatobiliary training in the same fellowship. And in 2025, 70% of our applicants are now US graduates. To become eligible to train in the US, if you're from, it all depends on whether you went to a United States medical school. And if you go to a United States medical school, you can either pursue general surgery or urology, as many transplant surgeons today remain urology, but the majority are general surgeons. And as long as you complete your exams, then you can apply for transplant surgery fellowship. On the right-hand side, if you didn't go to a US medical school, you have to be certified by, your medical school has to be certified by the US. Sometimes this might include you performing a US surgery residency. Even if you are a practicing physician, you may have to do a US residency training. And so some surgeons that have been practicing for many years outside the US, if they want to practice in the US, have to complete training in 1 to 3 years. You have to take all the exams that we have for our medical students, which is the USMLE or medical license exam, step 1 and 2. You have to obtain a visa approval, all right? And the visa approvals, as you have heard, may have heard, are very difficult now to obtain. J1 visas are solely for training, and H1B visas are our most popular visa, allows independent practice. And so practicing physicians who come to the US can obtain an H1B visa and become an independent practitioner. Unfortunately, this is the visa that our president has now charged as $100,000 US money to obtain. So what does training look like? What are the requirements of training in the US? The requirements for a transplant surgery fellowship is that it has to be at least 24 months, with 18 of those months being clinical work. The remaining 6 months could be additional clinical work, research, but most of the time it's usually more clinical work. And you can look at the volume here. The required volume isn't very high. You have to do at least 50 transplants over 2 years. All transplant surgeons who are graduate from the fellowship have to be proficient in multi-organ procurements, all right? And so you have to do at least 25 of them. You have to do at least 40 kidney transplants, 12 living donor nephrectomies, 45 liver transplants. And if you're certified in pancreas, you have to do at least 10 pancreas transplants, 10 back tables, and 10 procurements. And intestinal transplant which are very few centers. I'd say less than 5 centers in the US offer intestinal transplant training. You have to perform at least 10. And as you can see there on the right, each program might be a little bit different what they offer. They offer certification in kidney, kidney pancreas, liver, or everything, kidney, pancreas, liver, intestine. Most centers offer kidney, pancreas, and liver training. The focus is not just clinical work, but understanding how to care and manage transplant patients. And so the focus per our mission in the ASTS training regimen is technical mastery, transplant physiology, ethics, and innovation. And so what does training look like in the US now? Here, this is a robotic console and robotic surgery. And for any surgeons interested, I don't have it here on this presentation because it takes up too much data, but I have videos of robotic kidney transplants I'm happy to share. And this is just a still picture on the right of us doing robotic kidney transplant from a living donor. And this is us using the robot to do the anastomosis. And so robotic surgery has been around for many decades. A robotic kidney transplant actually has been performed for at least 15 to 20 years now. And I would say in the last 4 to 5 years has become very popular in the US. And I have to admit, if the rest of the world has been doing it for many decades, once the US starts doing it, then they act like it's brand new. And so that's just how we are. All right. Also, not only robotic surgery, but in the United States, we have a robust registry. And so this is a New York Times article from approximately 10 to 11 years ago, looking at the longest chain of kidney transplants performed, where approximately 60 individuals from one donor created a chain of kidney transplants. And what this means is that their donor and recipient were incompatible. But because we're able to accomplish these chains, we're able to get people transplanted all across the country. And this involves doing organ procurements or kidney harvest in one side of the country, sending it to another, and then sending it further down the chain. And the US training now has become revolved around the new technologies that we have. Hypothermic perfusion has been around for decades and is routinely used for kidney transplantation in the top left. The company TransMedics has now introduced their normal thermic kidney perfusion pump, and this has yet to be FDA approved. But this is something that's likely to hit the market within years. And again, allowing kidneys to receive normal thermic perfusion on the pump. And what they've shown in the preliminary studies that these kidneys are able to clear creatinine and make urine while on the pump. On the right is TransMedics FDA-approved liver perfusion, so what they call their organ OCS system. And so this has really revolutionized liver transplant in the United States and really across the world where you have these pumps. And that since in the United States, our procurements are now 50% donation after cardiac death, many of these livers are now placed on these pumps. And the data has shown that the risk of ischemic cholangiopathy, which is stricturing of the bile ducts, has decreased from 40% down to 5 to 10%. And so this allowed us to use livers from very far away, allowed us to use much older donors, and have changed what we call extended criteria donors. And so if you look at the trend, we're doing many more livers, mainly because of these perfusion pumps. And like I mentioned to the group here, organ procurements are no longer a procedure that you can do in a couple hours. Organ procurement surgeons now are responsible for placing these organs on the pump. And an average organ procurement now takes 4 to 5 hours to perform. In addition to that, we have normal thermic regional perfusion. And what this is donation after cardiac death or donation after circulatory death donors. One option that we have, instead of putting it on machine perfusion, is to reanimate the heart by placing the patient back on ECMO after they officially are declared dead. And in these situations, you can reanimate the heart and have it beat again so that you could then use the organs as if it's a brain death donor. Okay? And this picture is abdominal reperfusion. In the US and across so as you know, normal dermic regional perfusion has been performed, especially in countries like Spain, for many decades. And they have perfected this. In the US, we started doing this probably about 10 years ago. And what we have found is that, of course, there are ethical problems with reanimating the heart and perfusing the brain. And so what most centers are doing now is they're only reanimating or reperfusing the abdominal organs. And so this picture here is specifically looking at abdominal normal dermic regional perfusion with clamping of the aorta to prevent reanimation of the heart. And so this is and again, procurement surgeons will be responsible for performing this as well. And so that's a lot of the cutting edge technologies and new techniques that are being performed in the US and a lot of our training. So the question I have to ask myself is US training relevant or applicable to the rest of the world? And the reason I ask that is because looking at Brazil, which is a top global organ transplant center, you're doing this without pumps. You're doing this without DCDs. And I'm not saying that won't help you, but is it absolutely necessary? And I would say when looking back at history, in the 1960s to 1990s, the US was the training place for abdominal transplantation surgery. And that's because it was a relatively new field. And many surgeons would come there to learn and bring it back to their own country. But in the year 2000 and beyond, is it still applicable? All right. Are barriers to training in the US even worth crossing now that we have other centers outside the US that perform organ transplantation just as well as the US? All right. And these barriers I'm talking about include licensing, like I talked about, having the repeat residency just so you can be a clinician in the US, regardless of how much you've already practiced. The cost of living in the US is high. It is very high. Where I live in Palo Alto, or where I work in Palo Alto, Stanford is the most expensive zip code or most expensive area in all of the United States. We talked about visa issues, and of course, I bring up ICE. Everyone know what ICE is? Immigration Customs Enforcement, and we have this guy too. I count this as a barrier as well. All right. I won't say any more about him.
Yeah.
All right. Definitely a barrier. All right. And so that's US training. And so we have to ask ourselves, is the US still the best place to train? And so when I researched about Brazil, I found this article. And I know there was two articles looking at kidney transplant surgery training, one from Sao Paulo from years ago. This one was a little bit more recent. And so in this one, they surveyed surgeons in the, I'm not sure how to say, Minas Gerais. Yes. And I understand this is the state just northeast of Sao Paulo state, correct?
Yes.
And they have many transplant centers, and I believe they perform a good number of transplants there. So they did a survey study looking at the training of their surgeons, and they sent the survey out to 78 surgeons just within this region. 39 of them responded. And these are tables and graphs from the paper looking at where they specialize, what type of training they had, and on the right they look at why didn't they pursue specific training. So on the left-hand side, I don't know if this is on the left-hand side, you could see, let's see, right there, specialization or residency and transplant of kidney transplantation. How many of these surgeons who were performing kidney transplant actually received specialty training? And only 25% of them had received specialty training, or the majority of them did not, all right? And when they looked at the surgeons or surveyed the surgeons who did not receive specialty training, they asked them why. And so on the right side, 50% of the surgeons said because there was a lack of training programs, all right? A quarter of them said that it wasn't necessary, right? And a smaller percentage said it was difficult in time, meaning they didn't have time. or they kind of already did it through other means, okay? So this article that concluded based off this survey that, and please correct me if I'm wrong, but they said there are accredited specialized training programs in kidney transplant, especially medical residencies for it. But in the country, there are no guidelines on training, such as number of cases that you should do, what the training should look like, what are the goals of the training, all right? And these, training at these programs is not required and it's not enforced by the Surgical Society. And that transplant surgery itself, not kidney transplant, not liver transplant, but transplant surgery itself is not recognized as a specialty, all right? And because it's not recognized as a specialty, there's no government support, meaning it's up to the government to say that there is a position in transplant surgery available. But since it's not recognized, therefore they can't say it's a position, and therefore you cannot become one. And they concluded that formalized training is needed to really recruit future surgeons into transplantation. And so, based on what I told you about the US training and what Brazil, Hospital do Rim, São Paulo has to offer, what I see here in my days here is that in just Hospital do Rim itself, you have all the aspects of organ allocation and transplantation that exist in the city, most of it concentrated in the hospital. Our fellowship in kidney transplantation in the US can be accomplished through every single floor of your hospital, okay? All right, whether it's surgical care, medical care, organ allocation, and a world-renowned HLA lab that you have down the street from you, okay? That serves in most of Brazil. And if I look at Sao Paulo itself, if you were to create a transplant surgery fellowship that included kidney and liver transplant training, because I know there are some really excellent transplant centers, liver transplant centers here in the city, that you have the potential to become the first national training center for transplant surgery. As what I can see here is the guidelines and the development of a specific transplant surgery fellowship has yet to exist. And so you have the opportunity to really write this. So in conclusion, Brazil is a global leader in organ transplantation. There's no doubt about that. Training in the US and Europe may not be practical for everyone, all right? It is getting more difficult to go to the US to train. And the skills that you learn there may not be applicable to where you come from, depending on where you are coming from. Hospital do Rim and Sao Paulo itself have the potential to become the premier training center in organ transplantation. And this would be national within Brazil, all of Latin America, the Southern Hemisphere, and globally. So thank you.
Thank you, Tom. I would like to suggest you to put one conclusion more, that is in our hospital, we do the less expensive and also effectively. So we don't do laparoscopy for living donors, and we are not thinking about robotic because the cost is too high. And you see, we do a lot of transplant here, but there is a huge disparity between states in Brazil, and we have to work to have a more spread offer of transplant in the entire country. And the other very important issue for us is that the patients who are maintaining ICU in the community hospitals, you have seen all of our donors, they have high creatinine. So we have to work before going to these technical improvements. I guess we should work with ICUs, and also we work with the disparity. So we better stay, and for example, for the people who are starting at kidney transplant in Zambia, they better learn in our procedures than go directly to laparoscopic or robotic, because they are spending a lot of money for few patients. So we spend a lot of money for us for a huge number of patients. Do you agree?
I agree. And you know, the challenge though is that you look at like when you go to the world meetings, and people talk a lot about robotics. They talk about laparoscopy being the standard of care. It's hard to convince countries like the US and Europe, which have only trained their surgeon in laparoscopy, and many surgeons like myself, before coming to Zambia or before coming here, have never done an open nephrectomy. So it's very hard to convince them that what you're doing is better. They won't admit it. But that's why I say here is that what you do here is more applicable to the rest of the world.
Yes.
Because if you look at who offers laparoscopy, many countries in the West, Europe, and the United States do, but outside of that, you know, many developing transplanter centers don't.
Yes, I don't say it's better, it's enough.
Yeah, it's enough, yeah. And so that's where, to convince others, that's what you have to really point out, and that's what I point out here, that what you do is more in line with what the rest of the world is doing. Yeah.
So you spoke about the survey that was done in Minas Gerais, and the head of the first author of that paper is Elodie Sanders. She's she's online. Please, Elodie.
Hello, everybody. Good morning, and thank you, Dr. Pham. I'm very pleased to be our work presented by you, and thank you so much for your presentation. As Dr. Medina said, this was the study of one of my mastering students, who is a urologist. I am a nephrologist. I'm the head of the service, but I am a nephrologist. And this work came out to us because I work in a public hospital, a small public hospital. And we had some difficulties to, how can I say, to form our surgery team, because as many of them were urologists or vascular surgeons or general surgeons, so they have some kind of training in transplantation, in kidney transplantation, as it is part of our formal training. But in fact, they were not prepared to do all the procedures independently. So we tried to train them, and we had many difficulties to do this. And so that's why we raised the interest to analyze how is the training of the transplant surgeons in service in our state, that now is the second on the absolute number in Brazil. The first is São Paulo, of course, and then Minas Gerais is the second in the number. We perform 600 kidney transplants per year, I believe. And when we were looking at what our other countries do as training, so that's why I'm very pleased to know your program. It was really difficult to find what is necessary to do to be a transplant surgeon. Here in Brazil, they are trained as I said, in their specialized training as urology or vascular surgery, but we had only, if I'm sure, we had around 10 programs in all the country directed to training, especially in transplants, as many are in kidney transplant, and I believe 3 or 4 in liver and multivisceral transplants. So it was really difficult, and I'd like to ask you if, you know, I know that you are coming to Brazil for the first time, but here you are a huge country. You have many differences between all the states. As you know, that we have Hospital do Rim, but you have many other services that are not Hospital do Rim, and you have not all the structure to do kidney transplants. And if you look to our system, what do you think if you start a program to train surgeons here in Brazil? What do you think it would be a program? A program that that it can in fact train surgeons to do all the procedures independently.
Thank you, Erica.
Yes, you know, I think when I look back at U.S. training in the early 2000s, one of the things that transplant surgeons were not doing was that we were not recruiting our trainees well. And I'm talking about medical students, I'm talking about our surgery residents, all right? Is that we have to do a better job at incorporating them into surgery very early. And in the US, it is required that everyone do research. And I look at a place like Hospital de Rim, where you have great clinical research and leaders in academia. And I'm sure that's true in many centers across Brazil. But the idea is that we recruit by having them develop a career in transplant surgery. So that medical student, that resident, having them work with you in research is a great way to start recruitment, because that way they have the potential to become a leader in transplantation and then recruit future surgeons. And so we had to look back and see how we incorporate our own trainees into transplant so that they can decide to really pursue it as a career later on. I think it's very difficult, especially if you finish training and you had no exposure to transplant, and then you practice, and then you try to start doing transplant after your training. That could be difficult, but if you can plant the seed of transplant very early in the career, that would help you in the long run.
Yesterday we spoke about the harvesting, and many years ago I used to do harvesting, harvesting kidney, and I learned with Professor Salvatierra, Nick Feduska in San Francisco, and I have done for 10 straight years before the kidney hospital was organized. And by that time I used to do harvesting in block, both kidney at the same time. And today I just realized that people were taking one kidney each time. I guess it's more complex to do, and then I would like to have your comment on that.
Absolutely, absolutely. Can everyone hear me on the Zoom? Great. First of all, I want to thank you, Dr. Medina, for hosting me. And it's a pleasure and honor to be here in Sao Paulo and Hospital del Rim. So thank you very much. And I wanted to say the reason I came here was because of the reputation that you have in the world, and that many prominent surgeons in the United States recommended that I come here to learn more about kidney transplantation, more about training, and what you have to offer. And so again, thank you, and it's an honor to be here, as you have a reputation that expands all across the world, and how you built this program and how you're able to offer kidney transplantation to so many people in a very cost-effective and safe way with excellent outcomes. So thank you. To talk about a little bit myself, I am a surgeon who works out of San Francisco, California, technically in Palo Alto at the Stanford University. I've worked there for about 8 years now. I did my general surgery training in Columbus, Ohio, which is in the middle of America. And then I came to California, or came to Stanford, to do my specialty training. And my training, since I'm going to talk about surgical training in the United States today, my training was 7 years of general surgery, with 2 of those years being research. Following that, I did 2 years of transplant surgery fellowship training at Stanford, and then I had my first job in Los Angeles at the University of Southern California. And there I did, as a transplant surgeon, I did hepatobiliary surgery, I did general surgery, I did kidney transplantation, and I did liver transplantation, and adult and pediatric. And on top of that, we also did organ procurements. All right. And I was there for several years before I went back to my training site at Stanford, and I've been faculty there. Since I've been back at Stanford, I've had many opportunities to grow and expand my training. And so I am now the surgical director for living donor kidney transplant. And I'm also the surgical director for the pediatric kidney transplant, although I still do liver transplant as well. In the United States, many of the surgeons do everything. We all focus on certain organs. Some of us do more kidneys, some of us do more liver, but we're all able to do a little bit of everything when it comes to organ transplantation. We also do organ procurements. And I was surprised to find that you did organ procurements. You learned it in the US and you've done it for decades here in Brazil. And as far as organ procurements in the United States, traditionally, they were performed by the transplant surgeons. And they still are today. But something I'm going to talk about today is that organ procurements have become so demanding and technical that now we have surgeons who are dedicated solely to organ procurement. And that's because when you do your organ procurement, how long does it take you to take the kidneys out?
Yeah.
Maybe 15, 20 minutes.
Yeah.
In fact, yesterday I saw a living donor nephrectomy performed in 20 minutes. You know? But now,
Mario did it.
And in the United States now, with machine perfusion, normothermic regional perfusion, organ procurements now take 6 hours. Yes. And so it's become a profession in itself. And so organ procurement has changed quite a bit in the United States, where it's not just removal of the organs and leaving, it's all sorts of new technologies, because in organ procurements in the United States, approximately 50% of our organ procurements are from donation after circulatory death, or DCD donors. And because of that, these machine perfusion and normothermic regional perfusion has really, really taken off and become very popular.
So let me introduce Emmanuel, please, Emmanuel and Victor, just for you to give some comments about your 1 week here. We start in 10 minutes.
Okay, I'll see.
Because
good morning. I'm Emmanuel Victor. I'm a general surgeon from Zambia with interest in kidney transplant as well as cardiac surgery. I've been a surgeon for about 5 years from the time that I graduated. The training in Zambia for general surgery is 4 years, and currently I'm a PhD student. I've been here for about a week, and what I've seen is amazing. The organization of the different activities that happen, and also the efficiency in the kidney transplant, surgically as well as post-operative care by the nephrologist is excellent. And indeed, I am amazed. I hope that one day we can be even a quarter of what is happening here back home. I thank you.
Thank you. Victor.
Yeah, so good morning, everyone. So I'm Victor Maplanga. I'm a urologist by training. I trained in Zambia. Our training in Zambia, urology, is a direct entry. For medical school, you do internship, and then you go do urology, which is a 4-year training. So I trained at the University of Zambia, and that's where I'm currently working as a faculty. So in Zambia, I'm practicing as a general urologist. Now, with time, there has been need for kidney transplant. So I've transitioned to give up other activities and narrow down to kidney transplant. That's how we met with Professor Pham that wants to advance this kidney transplant. So we don't have a transplant surgeon in Zambia, and we don't have a fellowship. So we're trying to figure out who should be doing a transplant. That's how we thought, okay, we can collaborate, a urologist and a general surgeon. Both, we have agreed that we learn both the donor nephrectomy as well as the transplant itself. Currently, the transplant that we are doing in Zambia is living related. We are not yet at a stage of donor, deceased donor. We don't have a registrative so far. So that's why we thought we could come here and learn how it is done. So we've been here for the past 1 week or so, and we have learned a lot. Among the things that we've learned is having a system in place. And that's what we're impressed in. There's a system that does not give room for any mistake. Each one is specialized to do a certain thing, and they are accountable to that. And we think this is something that we can learn and replicate. So not only are we learning the surgery, we are also learning the system, including the organ procurement should we reach that stage. So we're very excited and we're very grateful that Pham was able to support us to come here and see how we can advance this kidney transplant program.
Thank you. Yes, Wilson is the head of the surgical team, and he has a comment or a question for you.
Tom, talking about it, about new technologies, in Congress, American Congress, European Congress, there is a trend trying to force the use of the robotic systems in many recipients. And we want to know your opinion about the use of the technologies in transplants.
Yeah, absolutely. And so there is a lot of news about robotic kidney transplant. And I have to admit, the reason why is because the kidney transplant procedure has not changed in 40 years. And so once we can do something new, everyone gets very excited about it. But what's very clear is that the indications for robotic kidney transplant are not very clear. In the US, one of our top centers that do robotic kidney transplant is the University of Illinois, Chicago. And the indication that they choose for robotic kidney transplant are the patients that are very obese. And we're talking BMI greater than 40 or 45, which is relatively common in the United States. And it is shown that, yes, the surgery is easier to perform in morbidly obese patients. But then the question is, should they even be receiving a kidney transplant? Those patients actually may benefit from weight loss surgery prior to getting a kidney transplant. Yeah. And aside from morbid obesity, there is not a clear indication for robotic kidney transplant, in my opinion. And I would say most of the data supports that.
Yeah.
But because in the US and Europe, we get excited about new technologies and wanting to use it before it is a clear indication. Hence, it gives us something to talk about at the Congress.
Yeah. Yes, it is an innovation, but there's no value for the transplant.
Yes, and my personal experience, and I have a video on my talk today, is that I do robotic kidney transplant. Yeah. And I do it because it's competition in the US, and it's for market, because in the US, there are over 250 kidney transplant centers. In the Bay Area or San Francisco area, we have 4 very busy kidney transplant programs, and we are competing with each other.
Okay.
And what do you think during the competition, the robotic transplant will grow?
I'd say right now it's very exciting and it is growing, but will it become the standard of care? I find that hard to believe.
I have a question. Yeah. I will ask a question to Patavino. Patavino is the one that organized the organ procurement. So he moved from en bloc retrieval from each kidney from each time. So why did you do that? Sorry? Você mudou a retirada do rim? Nós retirava em bloco, daí você mudou para... Por que você fez isso? Eu já falei com ele ontem.
I think it's a little bit easier to separate the both kidney during the surgery and the branch surgery. It's easy to remove the kidney without the way I was training. So I'm used to do in this way. I think there is no difference between removing it, separating in this patient or in the branch surgery. Yeah. Can I ask you a question about this transplant, the robot surgery? Are you doing now with single port or multi-port?
Okay. Very good question. I do multi-port robotic surgery, and there are some centers that are doing single port, but most of the robotic kidney transplants performed are from multi-port.
Because I went to the AOA meeting last year, and I saw that most of the people were talking about the difference between between open and robotic surgery, but now multi-port and single port. In your center, do you have the single port platform?
Yes, we do.
Okay.
Yeah, in fact, the single port platform was developed at Stanford because the very first surgeon to use it was ENT, or ear, nose, throat. surgeon, and so they helped develop it. In fact, the company, Intuitive, is only 20 miles or 10 kilometers away from our hospital.
That's
Yeah.
Thank you.
Yeah, you should go a little bit more on why you moved to Reutivo, yes. Because we would like to have you coming back to one block.
Okay.
I can comment on it.
Yeah.
And, I agree with you. As a surgeon, and you should do what you were comfortable with and what you were trained with. And if you're very good at splitting the kidneys, then it should make no difference. But if you're new to organ procurement, taking the kidneys out first takes it out of the warm body and lets you put it on ice sooner. And then you can split it on the back table as the kidneys are cold, instead of leaving one kidney in there as you take the other one out. But as you get faster, the time shouldn't matter.
Yeah.
But I would say that for people who are starting, and if it takes you a long time to get the kidneys out, perhaps taking it out in block, putting on ice, and then taking the time to split it might be a better option. But this is, in the United States, we say there's a million ways to do the same operation. But if you get the same result, I think it's okay.
Tom, once again, thank you for coming to our center. Thank you for your visit. We have observed a low interest among the new generation of undergraduate medical students, even young surgeons in the transplant field. How do you think that you could improve the interest for a career in transplant field?
I think that's a great question, and I could tell you our experience in the United States. And there was a study done looking at surgery residents who applied for transplant fellowship from 2006 to 2018. And what they found was that less than 30% of the graduates were from the US, meaning there was very little interest from United States surgery residents to go into transplant. And there were many reasons why. At that time, transplant was a surgery that happened in the middle of the night in the United States, and unpredictable hours. And there were very long surgeries, and perhaps it wasn't very appealing to a lot of general surgery residents. And so we as a group decided that we needed to change what we do if we're a transplant surgery. Because it used to be that one surgeon was on for the week and they did all the surgeries. And then the next surgeon would be on the next week. And one of the changes that we did is really to model what you already do here, where you have surgeons who work certain days and surgeons that work together to help each other. And so that you're never by yourself doing a difficult transplant, or if you have multiple organs coming, you know that you have help who can start the next operation. In other words, develop a team that works together. And that was lacking about 10 years ago in the United States. In addition to that, we changed training to include not just transplant, but we're also working with the Hepatobiliary Association, AHPBA, and that now graduates from our fellowships now can be certified in transplant surgery and hepatobiliary surgery in one fellowship. And what that has done for the US, it has recruited many US graduates to pursue transplant, because not only are they a transplant surgeon by certification, but they're also a hepatobiliary surgeon. And then you can also be a general surgeon. And so you have many options to do. And so that allowed people to explore more jobs outside of transplant. And so I would say in 2025, the number of US graduates that we have now are greater than 70% trying to pursue transplant. And so those are the changes that we made in the US to make transplant more appealing. Just basically better lifestyle. And number two, offering more certification.
Luis Moura, he's a pathologist, and he has been with us for 40 years. And he's our genius.
You can imagine that when I come to work with. It's interesting, as you are a surgeon and you are in the top of the procuring organs, how do you deal with these biopsies in those organs before transplantation?
And so the question is, how do we deal with and how do we interpret our biopsies? What we call donor biopsies or perhaps pre-implant biopsies. That's a really great question. For kidney transplantation, it is very controversial because many of the biopsies that we do in the United States are frozen sections. And frozen sections are very unreliable.
Yes.
Yes. And in fact, to give you an example, before I came here, I transplanted a kidney into a patient, KDPI 90%. The donor had a history of diabetes, had a slight AKI, but the biopsy was shown to have no glomerulosclerosis, no arteriosclerosis, very clean. And based on those data alone, it's hard not to use the kidney, all right? And so I chose an appropriate patient who was older and who could benefit from a kidney. The kidney worked right away, but the patient has proteinuria 3 months afterwards. And we did another biopsy, and the biopsy on permanent section, 3 months after the transplant, shows severe diabetic nephropathy, all right? And this is after our donor implant biopsy that showed that there was no disease whatsoever. And so in the US, we haven't figured out how to overcome this problem, although we don't know that it's a problem. We do have our biopsies read by transplant centers only. And so we don't have the biopsies read at community hospitals that don't have a renal pathologist. But it's because of cold ischemia time, we are not able to do H&E stains on all the donor biopsies. And so we have to rely on the frozen section and then also other data that we have. But it is still a problem. And so in other words, we take the biopsy, but we're reluctant to use all the data sometimes.
Tom, thank you for your presentation. As you could note, see on Sunday, the day when we performed 4 transplants and the day before we performed 6 transplants. So we have here a large-scale environment that can be an opportunity to have a speed learning approach in kidney transplant. And you showed me your presentation the number of transplants in a program of training. And my question is, do you think that how could you evaluate a trainer after the training in terms of the proficiency, the ability to become independent as a transplant surgeon? Time on training, number of transplants performed, or there are other kinds of this evaluation?
Let's maybe just make it. What is the percentage of the training in the transplant that actually goes on, and the percentage that the trainees that you say you have 2 left hands?
Well, I'll answer your question first. And training is always evolving. And so I'm going to take our general surgery training, for example, has changed from numbers of cases and length to it to proficiency, where the evaluator no longer says you've done 100 cholecystectomies. The evaluation says, can this person do a cholecystectomy? And the idea is to reach a threshold where you can say and do that. Transplant in the US is going towards proficiency, where we say this person can do a kidney transplant, this person cannot do a kidney transplant, as opposed to just saying this person did 40 kidney transplants, they can graduate. As we all know, trainees and surgeons, a lot of us vary in skill, right? Some of us need more training than others. And so how we evaluate that is that we are a 2-year fellowship. And so we spend a lot of time with the trainees, and we have time to develop them. And our expectation is that they will be able to do a kidney transplant independently by the time they finish their first year of fellowship. And until they can do that, then we don't let them do liver transplant, okay? And so you have to be able to do a kidney transplant independently, all right? Meaning we allow the trainees to do the kidney transplant. We are not scrubbed in. We watch them, we evaluate them, we give them feedback. And if you're able to do the kidney transplant with proficiency, then we allow you to do liver transplant, and then that's your road to graduation. Some people will take 6 months to reach that. Some people take a year. Some people, unfortunately, never.
Yes.
And so how do we deal with people with 2 left hands? We have to have an honest conversation with them. And we've had fellows where we said, you should not do transplant.
Yeah.
And then they go off and just do general surgery. It's rare, but you know, it's a small community. And if we give our graduate to one of our partners, then they'll never forgive us. Yeah. And so it's a small community. And so, yes, we have to be very honest with our trainees, and that if we don't think they should do transplant, then we have to let them know.
Is there a further question? Yes. Come here. Caio is a graduate student, and he has been part of our clinical research group.
Thank you for your lecture. My question is really related to the challenge that we still have here in Brazil of our programs of specializing surgeons on transplant. But what I see as a medical student is I know many professors like really good surgeons, but they all went out of Brazil to do part of their training. And here I see that we still don't have a great structure on our residence program, and we still have a point, that's the main point of my question. We have urology programs specialized on kidney transplantation, but also we still have this kind of abdominal transplant surgeons, but they don't do this residence program here. They have to do it there. So I don't know, you just mentioned that you have a scale of learning in surgical training, like kidney transplantation and liver transplantation, or you do multi-organ transplantation. But here we still have some surgeons that only do kidney transplantation, no? So if I have this goal to become a transplant surgeon, would I need to go to a specialized program on abdominal transplantation, or should I just focus on, you know, kidney transplantation and become urologist? What do you think would be the perfect goal for one who still have 10 years to learn everything?
Okay. Well, thank you for your question. And I'm going to split your question into 2 questions. One is training here in Brazil versus leaving the country to obtain training, correct? What I've seen here just in 2 days here is that you have very technically highly skilled surgeons here who can definitely train the residents to become very, very good surgeons. What is different in the US at academic centers is that we are very focused on training. In fact, training and education is deemed to be very important. So important that instead of us being paid as surgeons by productivity, we're paid to actually train. And so, for example, here at Stanford, you know, they give me the opportunities to come here to learn the certain skills that you have to offer. And they value this because they want me to bring this back to Zambia. They want me to bring this back to our own trainees. If you have a system where the surgeons are under pressure to perform as many surgeries as possible, and because this is how they get paid, and this is how you fund the hospital, then that's going to be the surgeon's priority, right? But if you prioritize teaching and have an academic center that will focus on teaching and transferring skills to their trainees, and the surgeons are paid to do that, then the mentality of training can change. And I think that's possibly one barrier that you may have. Go ahead.
No, go ahead, please.
All right. Your second question, whether you should specialize in kidney transplant, whether you should do transplant surgery, it depends on what you want and where it has to offer. If the country here is not offering transplant surgery and you want to do transplant surgery, then yes, possibly you will have to go outside the country. But what I wanted to really get across the message today is that Brazil can offer just as good training as anywhere else. You just have to change your mentality and focus and really put a priority on training. Right.
Okay, thank you. Before finishing, I'm going to introduce the next speaker for the next week. Na nossa próxima reunião, o professor Ricardo Cesso vai falar sobre o Censo Brasileiro de Diálise. We spoke yesterday about dialysis also. He's going to give information about the dialysis last year in Brazil. So before, you gave us a wonderful presentation, and you also gave us ideas to improve. And also, I would like to mention that you speak very clearly in capital letters, yes. So everybody can follow very easily. So thank you so much for coming here, and your word is yours.
Thank you for hosting me. I very much appreciate it.
Thank you.